So it mentions there about, we've been about 50 states and only 64 burn centers. That seems like way too little. And we've had issues here in the state of Mississippi even able to keep one open, and to, right now, I don't even know for sure. There was one over in the Delta area for a very long time. They shut it down. I think they moved it to Jackson. Maybe that one in Jackson is still open. But anyway, there's definitely a concern with that. People being able to get the specialized care that they need at burn centers when they're being available for them. So that's kind of one issue with the care. But as far as how burns are really, really, it can be caused by so many different things. You know, it can be house fires, it can be accidents, it can be so many different things that can cause them. Also, age, it really doesn't matter. I mean, we know that a baby could be in the tub and start pulling up and turn the hot water on and have a scald injury. So really, there's no limitation to the age, or there can be so many different causes. Obviously, probably populations that are at a greater risk would be those that are older, younger. You know, you think about anybody that may possibly have some type of immobility issues or anything, that with a house fire didn't have the assistance that they needed, how they able to get out. You know, you can see where some of those people could be, at a greater risk for injuries from that. It does say that cooking accounts, your book says cooking accounts for the largest percentage of fire-related injuries in residential settings. When you think about like grease fires and things like that, they can set your whole kitchen on fire. And then as far as the pathophysiology goes, the cause of the burn. So what is the etiology? Is it caused by thermal, electrical, chemical, radiation? What type of burn are we actually dealing with? We're also going to be looking at the depth of the tissue damage, and that's kind of how everything's going to be classified. That's going to guide the care for the client that has experienced the burn. You're going to be doing a calculation to determine the total body surface area that is affected. And so typically what we're going to kind of use, what you'll see reflected in the test, is the rule of nines. That's typically the type of calculation used. It's kind of general. It's not as specific as some are to give a very specific total body surface area, and probably maybe at a specialized burn center they may use something that is more specific, but the rule of nines can give a pretty good general idea about how the client's treatment needs to go. So, following along, this is on page 1150 in your book. A couple of things that I want you to think about too. I may end up repeating myself. Anyway, a couple of things that we really need to think about with burns is the fact that when burns occur, you're going to have a lot of plasma that's going to seep into the tissue. There's going to be capillary permeability is going to be greatly increased, and a lot of fluid loss is really one of the first concerns that we are usually addressing when we're dealing with a client with a burn. So when the fluid is all seeped out into the tissues and everything, and it's not in the vasculature, the body can't use it. And we know that in the low fluid volume state, the hypovolemia, all the other problems, the electrolyte imbalances and everything that can occur as a result of that. So, as a result of all of that fluid not being in the vascular system, how do you think they could present? Tachycardic. How's the blood pressure going to be? Very initially, you got to increase, and then as your body's dealing with it, hypotension occurs. What about the respiratory rate? Increased. Our body's doing everything to try and get the oxygenated blood or get more oxygen into the limited amount of blood or whatever. So all of that fluid moving out of the vasculature, that's creating hypovolemic state. So that's going to demonstrate a hypovolemic shock is how the client is going to present to us. How is the cardiac output, do you think, up or down? It's down because of hypovolemia, because where's all the fluid at? In the tissues, where we don't need it. How are the kidneys being perfused? Not well at all, because we're not getting the fluid where it needs to be. They're going to be holding on to every bit of fluid that they can because their body's telling them that they don't have enough fluid. So without the perfusion, they're not gonna work right. Very initially, we talked about a little uptick in the blood pressure, but then we know that as it progresses, high heart rate, low blood pressure is the symptoms of shock. So, but with all the stress, initially you may see some vasodilation because the body's fight or flight response is gonna be releasing that epinephrine. And then as the things progress though, the body's gonna begin to vasoconstrict and we're gonna be shunning blood to the major organs, which is typically the steps that you're gonna see and how shock is gonna be. So there may also be an increase in the ADH, that antidiuretic hormone, and aldosterone. So the body may release both of those in an attempt to try and hold on to what water it can, to hold on to any sodium. Because we know all the fluid's going out to the tissue, and so the body's trying to do everything it can to compensate and hold on to the water. So all of these things are gonna kind of all be happening at the same time, regardless of what type of burn. So as a result of the burn, the body's gonna be trying to respond in an appropriate manner. So we are gonna need to be sure. Talk about that. We're gonna need to be sure that we're monitoring. I was gonna say that specifically with the electrolytes, and we'll mention it again in just a minute. So we're gonna go into this a little bit more with the thermal, electrical, chemical, radiation burns. So with our assessment, what we're gonna do when they come in, we're gonna ask questions, we're gonna be finding out what caused the burn. So was it a thermal burn? They were in a house fire or a car fire, or had a cooking accident? Was it an electrical burn, or did they get electrocuted in some way? With any type of electrical burn, you gotta be sure that you are aware of where the electricity may have entered and then where it exited the body, and see what organs could have been between the entry point and the exit point to kind of guide your assessment to see if it maybe, did it affect the heart, did it affect, what organs could it have possibly affected. Chemical, the thing with that, it could be acid, alkaline, organic compounds, but the thing with the chemical burns is we're gonna need to find out, like, what is the antidote, or what is the neutralizer, okay? So it may not be safe to just splash water on them to try to wash it off. So that's just gonna take a little investigation, whether it's, if they have that, all chemicals that people are working around and everything should have that special, it's a name for it, but there's a special sheet on there that tells them like what type of chemical it is, and then what would be the neutralizer, and all the information about it, and what they should do, should they come in contact with it, and all of those details. So if they don't have that information, maybe, I don't know if the Poison Control Agency can help us with that, or if it could be the company wherever they were working, whatever we need to do to get a little further information to determine what would be the appropriate treatment. Is it gonna be water, or is it gonna be some other solution to safely remove that chemical from the client? And then radiation burns. So, I don't know if it gives any type of examples there. Sunburn, it says, is also considered a radiation burn. also think about, we talked about those clients last week that have radiation as a result of, cancer. So there again, you could be dealing with some type of, you're not gonna allow that burn to progress to a serious level. You know, the doctor's gonna be checking them and everything prior to, but just know that that can be a type of burn that the client can experience. And then I don't know if any of you all have ever watched that, Skinwalker Ranch show, where they're are they out in Texas? Is that where it is? They're out in Texas, and so I think that, but there's large amounts, like excessive amounts of radiation, and they're trying to get to the bottom of it out there. They're investigating, trying to figure out what it is. There's been weird alien type activity. It's crazy stuff going on. But anyway, there has been some people with some issues with the radiation and the burns and things like that. So there's several different ways that a client could experience the radiation burns. So the classifications, the burn depth is listed out. It's on the table there, table 51-1, page 1153 in your book, and then I've also got this right here to kind of show you a visual demonstration of some of the superficial partial thickness, deep partial thickness, and then full thickness. So that, I've got it labeled there. You can kind of see where, or the graph I found, the chart I found had it labeled to demonstrate how it used to be first, second, and third, and this kind of shows you how those middle two used to be second, but they've broken it down a little bit further. And so if you separate the superficial partial thickness and the deep partial thickness, you see that the superficial partial thickness is wet and pink, whereas the deep partial thickness is less wet, it's red, and it may have or may not have blisters. They can have blisters on the superficial partial thickness. They look wet, they tend to be more painful, but they can still have a good capillary refill time. It's not really interfere so much with the blood flow to that area. Whereas the deep partial thickness, we've kind of gone beyond that superficial dermis, and they can look more cherry red, and then also sluggish or absent capillary refill. So you can see the first superficial thickness and the superficial partial thickness still seem to have pretty good blood flow if they've got a good capillary, a fast capillary refill time. And then once we're getting deeper into the tissue, we've got more, it's more invasive, and it's affecting that blood flow more in the deep partial thickness as well as the full thickness. But just kind of look at those. That's very basic information. That full thickness, we got dry, white. We have gone through all layers of the skin and subcutaneous tissue. The full thickness can also look brown and leathery like. And so if you've got a full thickness burn that could be to the chest, we have to be concerned about that. We know leather skin is not going to expand and contract appropriately, so there we have to be concerned about, is it going to be interfering with the lung expansion? So whenever you've got something to the chest where you have the potential for the respiratory system to be compromised, that's got to be a high priority. A very serious thing to note as well with the burns is they are dynamic wounds, so that means that they can be continuing to evolve. So where you do an initial assessment and get a general idea of how severe the burn is, the burns can deepen over the first 48 to 72 hours. So this is going to be reassessing, and it may be difficult to know the true depth of the wound until we're 2 to 3 days after the burn. It says that even the burn specialists are only correct about 60% of the time. So, you know, like I said, you use the rule of nines, it's pretty general, you get as close as you can to identifying the total body surface area, but knowing exactly or being spot on is gonna be difficult, because to know exactly how deep it is, and also to know that it's evolving as well. So that total body surface area is gonna be expressed as a percentage, and we'll talk about that with how we're gonna use that. Because, any adult patients that have 20% or greater of their total body surface area burned, fluid resuscitation has to occur at the time of the injury.
You said 20%?
20% for adults, and 10% for those extremes, the elderly and the children. Yeah, so adult patients need fluid resuscitation with 20% of their total body surface area burned. And the elderly and the pediatric need resuscitation with 10% of their body burn. Because we know that they are much more sensitive to fluid shifts, and the pediatric especially, they don't have as much fluid to lose because of how small they are.
You said older patients need a routine.
Elderly
Elderly
and pediatrics.
and pediatric.
Yeah. So those extremes, you know that we always treat our elderly and pediatrics more sensitively than we do the adults. So it does mention the total body surface area percentages on 1155. And it mentions the rule of Palm, it mentions the rule of nines, the Lund and Browder classification. Those are the three main ones. The one for test purposes that I want you to remember is the rule of nines. For NCLEX, that's what you would typically see, would be the rule of nines. But you can see for the Lund Browder, you would get much more specific, because you see how it is broken down by ages. So, for example, we know that an infant's head is the largest part of its body, so the Lund Browder accounts for that. Whereas 0 to 1 year old is 19%, whereas for an adult, it's 7%, because it's more in comparison to the rest of their body. So the Lund Browder is just used, like I said, we give you much more specifics. But for test purposes, the rule of nines is appropriate. So those are on your slides as well, to kind of give you an idea.
You want us to know the percentage?
Yes, yes. So if you've got a question that tells you what parts of their body are burned, you're gonna need to be able to calculate the percentage. So each arm, 9.
So like, if it was like the hand and the arm, if it was both arms including the hands, it would be 20%.
Yes,
Okay.
that's correct. And I was gonna do the math real quick on the, I always wanna be sure about this.
So it's not like the front of the arm is 9% and the back of the arm is also 9%, making one arm 18%?
It's not.
It's not.
It's not. It's the whole, that's when I was double checking the math on
They
it.
do posterior and anterior.
Right, so if the front of the chest is 18, so that means the top half is 9 and the bottom half is 9, and the back of the chest would be 18, top half 9, bottom half 9. Does that make sense? So if it's the whole front of the chest, it's 18, if it's the whole back of the chest, it's 18. Each arm is 9
Okay.
total.
I got you.
The
Each
leg,
leg total is 18, so if it's the front of the leg, it'd be 9, the back of the leg, it would be 9.
okay.
Does that make sense?
Yes.
So if it's just the front chest and not the back, it's 9%.
If it's the whole front, it's 18. If it's the top half, it's half of that. So the front of the chest And really, you could think of the whole front of the body as 9, 9, and 9. And then the whole front of the body would be 18 and 9 and 9. And the whole back of the body would be 18 for the chest area and then 9 for the back of each leg. 'Cause each leg total all the way around is 9. 18. The whole leg is 18. Right leg and left leg. The front of the chest, anterior, is 18%. The whole back of the trunk area is 18% posterior.
So this is showing us front and back.
It is. Yeah, it's just showing you the anterior, and that's why they wrote on there, anterior is 18% of the trunk area, and posterior is 18%. And then each leg total, right leg totally burned is 18, left leg totally burned is
So
18.
only the front of the leg is burning.
Correct.
And then the
That would
hands
be
are,
half of it.
So the hand is
the
one
hands total 1.
Hands total 1, arms total 9.
So would that be 25?
Yes. If it was maybe just the anterior, posterior. It's not gonna be that extreme though. It's pretty much gonna stick to the 9s. Okay.
I get it.
So any clarification? So let's give an example. Okay, well, I'm pretty sure that I got a question on this later, but what if you had the anterior chest, the head, and the front of the right leg?
The front of the right leg, 20, 30, 25, 36. I know. 36, yeah.
Okay? What if you had the right arm and the whole right leg? Yeah, just the arm. Yeah, 27. What if you had the back of the left arm and the whole back of the chest, the whole back of the trunk?
27.
Wait, you
You
said.
still have 18. 18. Cause you said just the
The
trunk.
back of the arm.
So that's 4.5.
Uh-huh.
Oh.
The posterior trunk.
We need to just have this chart on the table. It's supposed to be
Oh, okay, I got it.
4.5 plus 9
Does the hands split too?
for the
It would.
Okay, so I got it.
Cause she said the whole posterior,
half,
like the front of the arm, so they won't have 9. Oh my God.
Maddie said, if the question referred to the back of the arm, the back of one of the extremities, the back of the arm or the back of the leg, that would be half of that extremity. So if you had the back of the arm and the whole posterior trunk, that'd be 22.5. 18 plus 2.5. But if it was just, we had a gentleman one time in the intensive care unit that put a cigarette out in the meth in his trailer. So he was burned from his hand and it ran all the way up his right arm, across the top of his back, and then down the left arm. That's how it is. Yeah. So note to self, don't ever do that, okay? And then he had briars all in his feet because he was running from the law and he ran into the woods. And then he got served papers as the police came to the bedside in ICU for intent to distribute himself. So, he was a rather difficult patient to deal with. You can imagine. So, that's a bad day. Then you're in the intensive care, you have to go into breathe. And then he went to, no, he was going straight to. So you never know when you may encounter, what now? Right, so if it was the face, if it wasn't the entire head, you could have any of those. But just plan in your mind 9, so that way, if it's double, you know, like if it's the whole anterior chest, so even you can, in your mind, if it helps to kind of split the trunk in half, and do 9 for the front, the top portion, and then 9 for the bottom portion, equal the total. Just think about it in multiples of 9. Okay? Alright, so that would be, like I said, just kind of use that one as your guide, the rule of 9s, to figure that out. What is the total body surface area percentage burn? And then also, the other thing that we've got to look at is the severity factors. So obviously, if it is an issue with an inhalation injury, so what may be some symptoms we could see on the client when we're doing physical assessment findings? What could we see maybe if it's an inhalation injury? Singed, right, singed nares, stridor, yes, you definitely could, because I could tell that there's some inflammation going on there in the throat, causing issue with them being able to breathe. You said the singed nasal hairs, what if you saw soot? Where would you be looking for soot? Around the nose, around the mouth. So any of those signs would let you know that we've got the possibility of an inhalation injury. So what's gonna be our number one priority with those clients? Airway. So we're gonna wanna be sure that we are monitoring their airway first. So whenever we have anybody come in with the burn, we're still gonna follow those ABCs. We've gotta rule out first, is there any type of injury or potential injury to their airway that we need to take extra precautions for? So the singed nasal hairs, burns in the mucosa, burns to the mouth, burns to the head, neck, face, or if they're coughing up any type of soot or black secretions. So all of those could be warning signs for us. We wanna be sure that we administer oxygen at 100%. And what is that poison that they can inhale that can cause carbon monoxide? So that would be the most common airway injury. And as we're trying to assess the situation, we need to know, did the burn happen in an open or closed area? Because if it was an open area, maybe the risk of carbon monoxide poisoning might not be quite as high. But if it was in more of a closed area, the inhalation injury, carbon monoxide poisoning, that could be a bigger issue. So one problem that you can have with doing a pulse oximetry on these clients is that we know that doing a pulse oximetry is not an invasive measurement, right? It's just telling you that the blood is saturated. How saturated is the blood? But it doesn't tell you if it's saturated with hemoglobin, or in the instance of a client that has suffered from a burn, it could be saturated with carboxyhemoglobin, which determines the amount of carbon monoxide that's been absorbed. So just simply doing a pulse oximetry, oh, they're sat at 99%. But it appears and everything indicates they have an inhalation injury. We gotta do some further testing. So what we'll test for them is the carboxyhemoglobin. Just a basic O2 sat would not be a good, it could be a very misleading measurement. So the O2 sat, we're gonna do the carboxyhemoglobin level instead. And because of the risk of that pulse oximetry reading being falsely saturated with the CO bound hemoglobin, carboxyhemoglobin. Does that make sense?
Mm-hmm.
So you understand why you would need to do a little further testing. And then it also mentions there like concomitant injury, you know, like what if it was a car accident and then the car caught on fire? So, you know, some situations, it can be a combination of things that occur as a result of, they've gotta burn injury, but they've got additional injuries as a result of the accident that happened. So, the anatomical changes, we talked a little bit more, you know, you kinda got the details of what the thickness, the actual thickness of the burn, and how that is going to appear when we are monitoring them. And then there are some different zones, and it does talk about those zones on page 1156, the anatomical changes. And so it just says very basically, that zone of coagulation, that's where the body had the most contact with the heat source. Probably gonna be the location of the most severe damage. And then the zone of stasis, that's gonna be the area surrounding that zone where the injury occurred. And then the next zone is the zone of hyperemia, and that is just generally an area of increased blood flow, because we know that's our body's way of trying to compensate with any type of injury or whatever. Let me see if we can get some more blood flow and rush to the site to try and offer assistance. And as far as the actual functional changes, that is solely gonna rely on where the injury occurred, because obviously if the whole entire right arm and right hand is burned, then we're gonna have functional issues with that right arm. If we have, like I mentioned to you, if there is burns to the chest, especially if it's deep and it's leathery, then we could have functional issues going on with the body being able to, with the individual being able to breathe. What if that diaphragm can't move up and down because of the injury to the chest? So that's really gonna depend upon where the burn actually occurred. Here's a picture of we look past that. And then, so, like I mentioned, the first thing, just like with ABCs, we're still gonna rule out any issues with the airway first, and if we've got airway issues, we're gonna spend time there first. Getting them on some oxygen, being sure that we can secure the airway. So, some of the main issues there, you've got carbon monoxide poisoning, and then it could be injury above the glottis, and like Tyra mentioned, you may have some stridor, if you have that. Or it could even be further down below the glottis, further into the lungs, which could just vary, and, that would kind of be, the symptoms that you're seeing would kind of help determine how far reaching that respiratory complication may go. We know with the cardiovascular system, the shock is a major issue, because we know that all that fluid is seeped out into the tissues, and it's not in the vasculature where the body can use it. So, think back to what we just talked about. It does say that the major fluid shifts usually occurs within the first 24 hours. And then that shock will slowly begin to, over the next 24 to 48 hours, the capillaries can kind of begin to regain their integrity, the permeability decreases, so they're able to retain the fluid back into the vasculature like it needs to be. So just like we know that the wound can kind of evolve over the first 48 to 72 hours, well, over the first 24 to 48, the body can kind of start trying to get things back in order and get the fluid back in the right place. So, if we have a client with some major fluid issues, what's some of that invasive monitoring that we talked about? The CVP could give us some good information. So, we need to consider possibly using some invasive monitoring. We need to be sure that, especially for those clients with a large percent of their body tissue burned, because they can have, the larger the tissue involved and the larger the volume issue, The pulmonary artery pressure monitoring could also be helpful because it can give us a lot of good information about how the heart in general is doing. It could help detect any pulmonary edema because we're gonna be giving them a lot of fluid. We know that they got issues with keeping the fluid in the right place, so we wanna run a fine balance there that we don't overload them.
Can you say the name one more time?
The pulmonary artery pressure monitoring, yeah. So that was the Swan-Ganz we talked about, with the pulmonary artery catheter in, we talked about that hemodynamic monitoring. So that's just gonna give us more in-depth information about the heart and then that pulmonary artery and detect pulmonary edema. Another thing that we've gotta think about too is if they've got, a large percentage of their body surface area burned, where are we gonna put blood pressure cuffs? Where are we gonna put electrodes to be able to get good information? So that's where the A-line, maybe, put an A-line in, would eliminate the need for the blood pressure cuff. It could give us a good waveform of the heart. It could, the CDP, pulmonary artery pressure, monitoring those sorts of things with the invasive could give us more information that if they don't have any skin on the chest to attach electrodes to, we gotta get other measuring devices in place to get the information we need. So then we want to be sure, like I said, there can be some major issues with, fluid and electrolyte imbalances. So thinking about their potassium level, thinking about their sodium level. And it could be that if they are, the kidneys aren't getting the volume they need in order to excrete well, maybe we've got potassium building up in the system. So we wanna be sure that we're monitoring those closely. Renal, it could be that the renal system could be affected. Well, number one, we know by the volume status, but again, also with electrical stuff. If there was any type of electrocution, the kidneys could be affected by that, where maybe that's where the current went through. The big thing with the GI system, they are going to be at an increased risk for ulcers, and I'm pretty sure that it's called the curlings. I'm gonna double check that. But there's a very, it talks about in your book, the decrease in their GI motility, the possibility for a paralytic ileus. But we do have to take extra precautions with them because of the, stress on them, the ulcers that can form as a result of that. So I'll double check that when we take our break and revisit that. Metabolic issues. So we know that the body, there's gonna be very much increased metabolism as the body's trying to work to repair the significant amount of damage. Their caloric needs are greatly gonna be increased, so it's gonna be very important that we try and give them, the appropriate amount of nutrition as their body's trying to work through this. We know that nutrition is very important to wound healing. Wound healing is gonna be very important to, taking care of the body. And then, we know that there are factors as far as, we talked about how we're gonna treat different ages differently and how different ages can be affected more severely by that. Of course, if there's other type of injury, they have to go through surgery. So there are a lot of other factors that we wanna listen to, that we wanna be sure that we're paying attention to. The immune system, so they're gonna be at a high risk for infection. So we're gonna wanna be sure that we do everything, keep things in place. Maybe they're already gonna be put on prophylactic antibiotics to try to help, because the last thing we need in this severe wound they're already suffering with is infection there too. And then, as a result, if the infection does occur, sepsis could be another risk that you have to deal with. And it does say in your book that, approximately 28 to 65% of burn patients die as a result of sepsis, so that number can get pretty high. So we wanna be sure that we are monitoring that. So some of the, we talked about a big deal with dealing with the inhalation injuries, and there is a picture there, and it just looks painful to look at. On page 1162 in your book, of this client got some major burns to the face. You can see the soot around the nose. They got an EG tube in, and then they have the mechanical ventilation. They got an ET tube in place as well. So it's going to be very important, like I said, like I mentioned too, to identify if the injury was above or below the glottis. Monitoring for the carbon monoxide poisoning is going to be important. So if it's above the glottis, that's going to be like the nasopharynx, the oropharynx, and the larynx. Usually these are going to be more thermal. So, you know, it was a house fire and they were near the flame. That's where usually that above the glottis injuries are going to come. And then below the glottis, it says that's usually more chemical in nature, so something was ingested that caused damage below the glottis. And it makes sense too, because I mean, fire's not gonna penetrate that far down. Something's gonna have to be ingested to get into the body that way. An inhaled chemical that would actually enter. Fire's not actually gonna enter. And I mentioned the electrical injuries. I think it's kind of funny, the book kind of calls those the grand masquerader, because they could present physically like when you can't see it, because you can't visualize all the damage and burn that went on, that happened inside your body. So the extent of tissue damage, you can't see it, so that's where we're gonna need some more invasive testing. It does say in the field that it would be important to get the client in the C-spine. They need the cardiac monitoring for a minimum of 24 to 48 hours to be sure that if the heart was potentially involved in either of that. They are gonna be at a high risk for ventricular fibrillation, which we know is gonna require defibrillation if they're unconscious, or cardioversion if they're conscious. And then some of the renal studies that you're gonna look at too is there a lot of blood in the urine? Is the kidney excreting myoglobin, which tells you that there's a breakdown of the muscle. And those myoglobin, it's really large, and so it can do damage to the kidneys as it is going through those nephrons. So like we mentioned, the renal issues are gonna be more associated with, mention the volume, and then the specific type of burn that the renal are more connected with is the electrical injuries. And the chemical injuries, I already told you, if it's especially anything to the eye, it needs to be flushed continuously. We would use the guidance from an ophthalmologist to help us with that. And then removing the chemical is the priority, so removing it would be appropriate solution. And then removing the chemical is gonna be a high priority, but we gotta know that we have the right solution that is going to neutralize it. You see a picture on page 1164 and 1165 that shows the escharotomies and fasciotomies. So they are gonna be at risk for developing compartment syndrome. We're gonna talk about that in a little more detail when we talk about the musculoskeletal injuries next. But what happens pretty much is that compartment where the muscle is, it's kinda like we talked about the skull yesterday, it can only expand so much. And then once the swelling and the damage occurs to a certain degree, and it can't swell anymore, it starts cutting off blood flow, and then we're at risk for, they're gonna have severe pain, then you're gonna be at risk for losing limbs and things like that, because the blood flow is completely cut off. So, in this situation, they're doing the escharotomy, they're making incisions in the tissue to, release the tissue, to allow, like I mentioned, if their breathing is affected, you can see the exact pictures of where they would actually cut in the chest to release that tissue, to allow the chest to expand appropriately. And it's an escharotomy because eschar is that thick, tough tissue that forms, and they're trying to cut through that eschar to release the tissue. And then fasciotomy, we'll talk about that more, but the fasciotomy is where they actually release the fascia that's enclosing the muscle. So releasing that fascia allows the muscle to swell, the bleeding or whatever, until that can get taken care of, but it can save their limb by doing that fasciotomy.
That's cool, how they like cut the,
Could you imagine taking care of that patient? It just seems like they would look like a robot almost with all of these. Ooh. It looks rough. Working at a burn center would be hard.
those are the cuts right there in the book that they make right there?
Yes.
That's cool.
So, page 1164 and 1165, showing those cuts. So we're gonna go ahead and take a break right there, because I wanna be sure that you are, take your break and come back at 10, and then we're